Oh, I was very good. Trekking into the forest, like full of beaches. But it was worth it. Then you were told no only. Every morning. I was very happy. Trekking into the forest, like full of beaches. But it was worth it. Okay, like
क्या सर? हाँ सर, दोनों सर, आप दोनों करके दीजिए सर, चलेगा। इसको माइक को रिलीज माइक हाँ वो ऑन करना सर को बोले सचिन सर ಕೇಳೋದು ಅವರಿಗೆ ಇಕ್ವಲ್ ಆಯ್ತು ಅಂತ
Sachin sir, please say yes if you are able to listen to me on YouTube or on Zoom. Am I audible?
Yes, clear.
Is that clear? This is a test drive. So the mic, personal mic is working. Okay.
A very good morning to all the dignitaries and delegates who have joined us face-to-face as well as virtually. At the outset, we are happy to share that we have more than 400 delegates who have registered. I, Dr. Pulkit Kedia, welcome you for today's webinar on data analytics and real-world experience, a new approach in evidence-based medicine. Jointly organized by Department of Pharmacology, JN Medical College, KLE Academy of Higher Education and Research, Belagavi, and Indian Pharmacological Society, local branch, Belagavi. Conducting webinar on current trends in pharmacology by subject experts in honor of Sir Colonel Ramnath Chopra, the father of Indian pharmacology, is part of the culture of our department. I would like to give you a brief background about today's webinar. Data analytics enables users to rapidly ingest, standardize, and integrate data to generate insights from a variety of clinical and related non-clinical data within a single data ecosystem. The value of real-world evidence lies in deep insight generation to inform decision-making. Throughout the entire product lifecycle, real-world experience has become an increasingly important source of insight. To understand the clinical and commercial context in which products will be positioned, as well as to optimize the design of clinical trials, for example, by informing patient selection. May I now request Dr. Naina Hasilkar, Organizing Chairman, Professor and Head, Department of Pharmacology, Kahir's JN Medical College, Belagavi, to please deliver the welcome address.
A very good morning to all of you. Greetings from KLE Academy of Higher Education and Research, JN Medical College, Belagavi. Respected dignitaries on the dais, Principal Ma'am, Dr. P. A. Patil, Professor and Head, Department of Pharmacology, USM KLE. Guest speaker, Dr. Ravi Shankar, faculty and delegates. The Department of Pharmacology actually takes pride for setting a trend and culture of celebrating the birth anniversary every year of the father of pharmacology, Indian pharmacology, Sir Colonel Ramnath Chopra. And as a mark of respect and to honor his contributions to the field of pharmacology, the Department of Pharmacology always conducts academic events on this day. This year, we are celebrating 140th anniversary of Colonel Sir Ramnath Chopra. And this year, we have with us Dr. Ravi Shankar, who is our own alumni, who will be delivering a guest lecture on a novel topic that is data analytics and real-world evidence, a new approach to evidence-based medicine. I take this opportunity to extend a warm welcome to our beloved Principal Ma'am, Dr. N.S. Shetty, who has always been a source of inspiration and support for all our academic events. Welcome, ma'am. It's also a pride to welcome our guest speaker, who is our own alumni, Dr. Ravi Shankar, who has reached heights in his professional field. I also extend a warm welcome to all the delegates, faculty, to this webinar, and I'm sure this webinar is going to be a very enriching learning experience to all of us. Once again, I welcome one and all to this gathering. Thank you.
May I request Dr. Urmila Kagal, Professor, Department of Pharmacology, Kahir's JN Medical College, to please present a floral bouquet to Dr. N.S. Shetty, Principal, Kahir's JN Medical College, Belagavi. May I request Dr. Rekha Naira, Associate Professor, Department of Pharmacology, Kahir's JN Medical College, to please present a rosebud to Dr. Naina Hasilkar, Organizing Chairman, Professor and Head, Department of Pharmacology, Kahir's JN Medical College. May I request Dr. Netravati Kavi, Associate Professor, Department of Pharmacology, Kahir's JN Medical College, to please present a bouquet to Dr. Aarti Bhosle, Assistant Professor, Department of Pharmacology, Kahir's JN Medical College, Belagavi, and Organizing Secretary, IPS, Belagavi Branch. Thank you, everyone. Light is a symbol of brightness and prosperity. Light signifies the presence of the divine. Taking it as a symbol of blessings, may I request Dr. N.S. Martha Shetty, Principal, Kahir's Jain Medical College, Belagavi, along with other dignitaries on dais and faculty of Department of Pharmacology, to come forward to herald the auspicious occasion of this webinar by lighting a virtual lamp.
ఇక్కడేనా ఎస్ ఇల్లు సార్ అల్లే నెట్వర్క్ ప్రాబ్లం ఎస్ Yes, ma'am.
May I request all the dignitaries to please pay floral tributes to Sir Colonel Ramnath Chopra.
இன்னைக்கு ரெண்டு பேரும் கம்ம கம்மன் பூ வச்சிருக்கீங்க என்ன ஸ்பெஷல் யாரோ ஒருத்தர் பூ எடுத்துட்டு வந்து கொடுத்துருக்கீங்க ஓ
on merit in 1908. He returned to India early in 1909 to take up medical service career. So, the professional and academic career of R.N. Chopra started in 1921 when he joined the Calcutta School of Tropical Medicine as the first professor of pharmacology in India. Also, he was the first to establish a center for study and research in pharmacology in India. The first research paper published mainly on the studies related to therapeutics and synchronoalkaloids. Such studies demonstrated for the first time in India the dangers involved in employing heroic doses of alkaloid drugs in the treatment of all types of dysentery and malaria. He did extensive studies centered around tropical disease and prospective remedies like oxytocin, action of mini, synchonin, synchronizing effects on blood pressure, action of emmetin on thyroid and adrenal glands. The chemotherapeutic studies were carried out in connection with diseases such as malaria, amoebic dysentery, Kala-Azar, and filariasis, etc. He confirmed the value of cobra venom in relieving pains of indefinite nature in a large number of patients. Sir published numerous papers on occasion of antimony, on action of antimony and bismuth compounds. He did remarkable research on
Yes.
which is the traditional, nothing but traditional medicine comprises medical aspects of traditional knowledge that developed over generations within the folk beliefs of various societies, including indigenous people before the era of modern medicine. Colonel Chopra used the term indigenous drugs in its widest sense, including natives as well as plants introduced from outside and had become completely naturalized. The colleagues who worked with him stated he sowed the seeds of self-reliance and triggered the movement of scientific research on traditional Indian medicine. Out of the long list of indigenous drugs examined, a mention may be made of following few. The main one are Halorina antidysenterica, which is also known as Kurchi, is widely used in traditional medicine system for treatment of constipation, colic, and diarrhea. Plantago ovata hispagula is common source of psyllium, a type of dietary fiber for the treatment of constipation. Next, Terminalia arjuna or arjun. Its bark decoction is being used in the Indian subcontinent for anginal pain, hypertension, congestive heart failure, and dyslipidemia. Hevetia verifolia or yellow oleander. The leaves in decoction are taken to treat jaundice, fever, and as a purgative for intestinal wounds. Sir and his associates carried out pioneering work on Wolfia serpentina, a plant which gained prominence 2 decades later as a source of reserpine. He collected and analyzed information on poisonous plants of India and identified 700 poisonous plants found in India. Sir established the herbarium of medicinal and poisonous plants, collecting 6,000 specimens of about 1,600 species, represented about 2/3 of total species of both medicinal and poisonous plants occurring in India. Next, his research was on drug addiction. The importance of psychological aspects of treatment of drug addicts was stressed by Colonel Chopra, and as he has pioneered the research in India in the field of addiction of alcohol, opium, hemp, and cocaine. He did research on hemp, cannabis sativa addiction, describing the cultivation of hemp, its active principles, different preparations made for the purpose of its use, and modes of indulgence, pharmacological action of hemp drugs, and their role in habit formation. When R.N. Chopra sir joined as a professor at the Calcutta School of Tropical Medicine in 1921, he held the rank of major in IMS, Indian Medical Service. He got to be a lieutenant colonel in 1927 and colonel in 1934. It was his work on drugs enquiry committee and fine services to the school that brought to the Colonel Chopra recognition of brevet rank of colonel as honorary physician to His Majesty the King. He received various medals from School and University of Calcutta. Few to mention here are Minto Medal, Maud Medal, and God's Medal, etc. He was elected as a Fellow of Asian Society of Bengal in 1933, and in 1939 he became the Vice President of Society and also received the Barclay Medal of the Society. He was elected as the President of National Institute of Science, to which he had been a Foundation Fellow. He was awarded the Science Degree of Cambridge University for his contributions to the science of medicine. Colonel Chopra was elected to honorary membership of the American Society for Pharmacology and Experimental Therapeutics and Pharmaceutical Society of Great Britain in 1940, and a corresponding member of Belgian Society of Tropical Medicine. Colonel Chopra was conferred knighthood in 1941 New Year Honours List. This picture showing Sir R.N. Chopra receiving Dr. E.R. Smith Award of the Indian Pharmaceutical Association from Mr. Homi Taryar Khan, then the Health Minister of Maharashtra. The Indian Pharmaceutical Society for his work had been given Chopra Memorial Oration in 1976, and in Chopra's honor, Indian Post and Telegraph Department issued commemoration stamp on 17 August 1983. The most important, he was the chairperson for this committee, Drug Enquiry Committee, which was important. Which played an important role for pharmaceutical developments. In August 1930, the government of India appointed a committee to study the issues of substandard and counterfeit drugs and make appropriate recommendations. Sir Chopra sir was chosen to chair this Drug Enquiry Committee, and he brought about significant recommendations which helped the pharmaceutical development in the country. Few to mention here are the Drugs Act 1940 was enacted, which later changed to Drugs and Cosmetic Act 1940 in 1962. The scope of statute was further widened through the 1964 amendment. The provisions were expanded to bring Ayurvedic, including Siddha and Unani drugs under his. Next, the Pharmacy Act 1948 was legislated for control of pharmacy, and this committee also created advisory board in which Colonel Chopra continued to draw attention to the menace of drug adulteration and sale of spurious drugs. And next one to mention, this committee also brought about compilation of Indian pharmacopoeia and establishment of central laboratory. As prelude to these developments, the government of India established Biochemical Standardization Laboratory at Calcutta in January 1937 with Colonel Chopra as the director in honorary capacity. It took 9 years after pertinent recommendations of the Committee for the Drugs Act 1940 to come forth, and per provisions of the Act, the Drugs Technical Advisory Board was constituted in 1941. And the most important milestone in our pharmacology history is development of Indian pharmacopoeia. A committee was constituted with Sir Ramnath Chopra as the chairman to prepare an official pharmacopoeia list in 1940. The Indian pharmacopoeia list got ready and was published in 1946. It was intended to serve as an Indian supplement to the British Pharmacopoeia in 1932. The first Indian Pharmacopoeia Committee was constituted in 1948. Sir Ramnath Chopra continued on the committees involved in the preparation of Pharmacopoeia of India, Indian Pharmacopoeia in 1955 and its 1960 supplement, and the new edition of Pharmacopoeia which followed in 1966. Sir Ramnath Chopra passed away on 13 June 1973 at his own home in Srinagar, Kashmir. Professor Chopra raised himself almost to the status of an institution rather than an individual. A glorious career seldom to be achieved by most medical scientists in India. David Colonel Sir Ramnath Chopra is and will always be remembered as father of Indian pharmacology, as a pioneer of systematic studies of indigenous drugs, a promoter of Indian system of medicine, and a patron of pharmacy. In a recent account of history of pharmacology in the Indian scenario, it is noted the history of pharmacology in India must always begin with Colonel Sir Ramnath Chopra. Before the arrival of Colonel Chopra on the scene. Materia medica was taught in medical schools, and the concept of pharmacology as a separate discipline did not exist. This aligned my brief introduction to Sir Ramnath Chopra. And for further information, you can refer Chapter 1 of textbook titled History of Pharmacy in India and Related Aspects, Volume 7, Credos and Awareness Status of Modern Pharmacy, Volume 4, Sir Ramnath Chopra, Work, Vision and Legacy by Vallabh Prakash. Thank you.
Thank you, ma'am. May I now request Dr. N. Smart Chetty, Principal College, JNMC, Belagavi.
I need that or the speaker will do. Speaker is na? Speaker. Idrag matadle ಏನು
A very good morning to all of you. HOD of Department of Pharmacology, Dr. Naina Ashikar. The speaker for today, Dr. Ravi Shankar, EC. And our senior teacher, Dr. P.A. Patil. All the faculty members of the Department of Pharmacology. We are postgraduates. And most importantly, the delegates who have joined online. I think I'm really honored to be here on the occasion of the 148th birthday of Shri Colonel Ramnath Chopra. His biodata, I think, is an eye-opener to all of us. A man in such a short lifespan can contribute so much, not only mankind, but to the subject. Can you imagine where his degree was a BA actually? I don't know how much of science was there at that time, but definitely his contribution to the tropical diseases medicine, or I should say his all the anti-malarial or anti-constipation drugs, etc. Not only that, but at that time he had thought of studying our medicine and integrating it with the modern medicine, which today we are even today we are struggling to do that. We are not able to identify those, the elements that are present in our traditional medicine sufficiently. I think we are doing some work, but not adequate enough to make a mark and put our landmark on the global map. If that's what he tried to do, and look at what all he has achieved. Not only that, even during those days, he had tried about de-addiction. I think this is remarkable, and it is an eye-opener to all of us here. Probably he was totally involved with clinical medicine, and that's what kept him on his toes to find out what is happening with the medicines that are being given to the patients. That is where the key is, not only working in industries, but the key is knowing what the medicine does to the patient and how the patient reacts to it. Because we are a different population, whatever it is, the Asian population and the Indian population is entirely different. What literature we have is mostly from the West. So we need to study our patients. We need to look at the data of our patients and see how the drugs react. Only then I think we'll be making a difference in the pharmacological aspects of the industry in our country. I think it's an eye-opener, and all of us need to really think about it. I, looking at it, feel that my life at least is wasted. We have not done enough. We really need to do a lot more for the service of this mankind. The very fact that we have got our degree means that we have to really serve the humanity and see that we really think something like him. We may not be like him, but at least start thinking like him for the youngsters here. Only then I think will definitely make a change in the pharmacology aspect. Coming to today's data analytics, I think that's what is what must have ignited him and triggered all the research. That's the basis of any research. We need to have a good data analytics. And let's start with our own hospital. And I'm sure there'll be a lot to learn if you go around with the medicine people or with even other departments. You will learn a lot. What we learn in the books may not be happening there in the patients. Definitely that will help us to build up the research in our institute. And I'm sure Dr. Ravi Shankar AC will give more insight to all these aspects. And at the end of this oration, we'll definitely go more enlightened and hope all of you all get stimulated to think about the Dr. Chopra and try to emulate at least some part of it. Thank you.
May I request Dr. Pawan Malhotra, Director Principal, Professor of Pharmacology in Jammu, to please share a few thoughts.
Thank you very much. Am I audible?
Yes, sir.
Thank you very much for organizing such a wonderful seminar. The idea of me intervening in this seminar was that I am one of the descendants of Colonel R.N. Chopra. One of my colleague is also Dr. Vipender Singh Chopra, is also descendant of Colonel Sir R.N. Paternal side is Colonel R.N. Chopra and Dr. Chopra's paternal side is Colonel R.N. Chopra's family. In fact, a couple of things which are not known to the public about Colonel Chopra, that was apart from his research in pharmacology, apart from his role in Drugs and Cosmetics Act of 1940, apart from his work on Terminalia Arjuna and about Rahulfia Serpentina, he was a very kind-hearted person. He had donated acres and acres of his personal land for development of a drug research laboratory in Jammu, which is now called as Indian Institute of Integrative Medicine, which stands on his personal land. And that IIM is now a part of CSIR. That is number one, which I wanted everybody to be known. And the second thing is that Colonel Chopra was an FRCP from Edinburgh. The third thing is that Colonel Chopra, in recognition to his duties, in recognition to his services rendered in the field of pharmacology, he was the first nominated member of the state J&K State Legislative Council in 1955. It is not that that J&K government has honored so many times Colonel Chopra, but Colonel Chopra was a person who never came forward to accept those honors personally. There is a hospital in Government Medical College, Jammu, which is named as Colonel Chopra Memorial Hospital. So he never bothered to accept these honors because he was truly an academician and was totally fascinated with pharmacology and its development in India. Thank you very much. I just wanted to speak this much only, and I wanted to apprise the gathering some unknown facts about Colonel Chopra. Thank you very much.
Thank you, sir. That was very insightful for us to know. We now move forward to our scientific session. For this, we are proud to bring on board our alumni, Dr. Ravi Shankar AC. Okay, sir had started off as a regional medical advisor at AstraZeneca after his post-graduation at Carrier's Jain Medical College. Then he went on to be the medical advisor at Abbott, India, following which he worked in Mylan for 6 years, where he became the senior general manager. Currently, sir is working at Viatris as Head of Global Specialty Excellence and Medical Services. Sir has handled life cycle management of some of the key products, including conducting clinical studies, introducing products in different countries, and conducting medical education programs covering healthcare providers and patients to facilitate evidence-based disease management. In his 11 years of experience in medical affairs, Sir has been a part of several global clinical studies and has also led a team of more than 120 professionals based in different countries. Glad to have you with us, sir. Before we go ahead with the session, to ensure that the session goes smoothly, we request our participants to please raise their hands virtually if they have any questions. Questions will be taken at the end of the session in the sequence in which they were raised. If you have any connectivity issue while asking the question, you can post it in the chat box at the end of the session. May I request you, sir, to please begin the session now.
Yeah, thank you so much. I hope I'm audible. Okay. At the outset, I thank Dr. Naina Hashilkar, Dr. Aarti, and my beloved teachers for giving me this opportunity to talk on this important topic, which is evolving. In next 45 minutes or so, I would like to take you through data analytics and real-world evidence and how it is shaping the current decision-making process. So give me a moment for me to share the screen. Please let me know if you can see my screen.
Yes, sir.
Perfect. Thank you all. So maybe I'll start with giving a brief overview about the data development program while introducing any new country. And then we can move on to understand specific about real world evidence. What are the different strategies to develop real world evidence and how this can really help us in one approach of real evidence-based medicine and to also bring in insights on public health and patient care at large. So if you look at the data development program, it all starts with preclinical studies when we invent a drug. Then we move on to phase 1, phase 2, phase 3 programs. With this, we will develop a dossier, which includes all the data that's developed through clinical trials to regulators to get approval. But here, we may not know everything about a drug. Now, because we have studied drugs in a controlled setting, so we need to understand how this drug really works in a real world setting when physicians are using it in their day-to-day patient care. So that's where the phase 4 studies come into picture, that is conducted after approval of a drug and introduction of a drug in a country. Now, again, in phase 4, we can have an interventional study or we can have an observational study. So the real world evidence is largely categorized into a non-interventional observational studies. And these are gaining importance in the current era because of the insights they bring in into the patient care. Now, this real world evidence can be prospective, that is, we go forward and understand how the patient responds to treatment, or it is retrospective. So we go back in time and say what happened to this patient and how this patient was treated and how and what are the outcomes. So some of the examples of retrospective data collection, again, I go more in detail in future slides for each of these, is reviewing case records in primary and secondary care hospitals. So nowadays, most of the Indians are getting health insurance and health claims. These are one of the key resources for us to collect real world data. And this is what we've been doing in Europe and US, where there is already structured data available in the digital form. Now, many hospitals have implemented electronic records, and this can be of real value add for us to do the insight mining. And then clinical chart reviews can also help us to know how things are going. In terms of prospective, we do prospective studies for different reasons. One, we may want to know the safety of a product after introduction into the market. So we call it as PAS studies, that's post-approval safety studies. We may do an observational study to look at efficacy outcomes. We may do a pragmatic study, which is somewhere in between a pure observational and interventional study, a light touch, as we call it as low interventional study, for us to develop data on some of the interventions that can really help in assessing the tools that we have in patient care. Registries also fall under this category. Pharmacoeconomic studies have been gaining importance. These are pivotal data points for us to launch any drug in US and Europe. In India, it's now gaining importance, and a lot of focus is given for these. And again, post-prospective chart reviews are also part of this. Let's look at what is real-world evidence as per the definition. Now, US FDA states that any data that is related to patient health or delivery of healthcare, it's both, it's not just the patient health, it's patient health and or delivery of healthcare in the real-world setting. And the data can come from various sources. So as we discussed in the previous slide, it can come from health records, claims, registries. And now patient-generated data is also gaining importance. Now, most of you may be wearing wearables, smart watches, which will monitor your health. It will help you know the blood pressure. It will help you know the cardiac function, pulse. So these data can be collected centrally and analyzed at the patient level to see how patients have been doing or how general public have been doing in different parts of the country. There are also mobile devices, digital therapeutic solutions that are helping in remote monitoring of patients. So when you're remotely monitoring those patients, you're also capturing vital data of these patients, which can then be analyzed to gain insights into the intervention that we did to those patients and what benefit patient got because of the intervention. Now, depending on that, we can fine-tune our approach. Now, this is about real-world data sources. Now, what is real-world evidence? Now, we do the analysis of this real-world data, and that's what the 21st Century Cures Act states, that any evidence that is developed from the real-world data that provides insights into the usage of a drug, its potential benefits or risks, it's not just the drug, any intervention for that matter, in a non-randomized clinical trial setting is termed as real-world evidence. Now, going to more specifics on real-world evidence. We said hospital is a key source for real-world evidence. So medical records are managed in hospitals, whether it is paper records or nowadays, most of the hospitals, tertiary care hospitals have digital health records, which can add data into the real-world pool. Pharmacies also play a major role, and in future slides, I will show how these can provide some insightful information about patient care. So these pharmacies will document prescription information, and these can also provide vital information on the behavior pattern of the patients, compliance of the patients when they're on specific treatment. We will have claims database. These are more mature in developed world, but now even in India, a lot is happening in this space where there are a number of organizations who are focusing on developing data through claims database. So these are like health insurance claims when you go and submit either for cashless or reimbursement. So there the health data gets captured. You can do analysis in these health claims to know key interventions and outcomes in patient population. And the last piece is more of a prospective design studies like survey, registry or pragmatic studies that can help in patient-reported outcomes to understand how patients are responding to a specific intervention. Nowadays, social media is gaining importance. Social media can provide a lot of insights to us on what's happening to patients and patients' care. There are web crawlers available. You can put in the keywords in the web crawlers. Say I say drug A plus disease A. And then if I press submit, it will crawl through the social media channel, extract all the relevant conversations that are happening on that, and it will give us key insights on what is the discussion ongoing, what are the challenges that are out there in managing the disease, what are the patient-reported outcomes, what patients are talking about this disease, what physicians are talking about this disease. So this can give us a lot of insights on planning our healthcare delivery in an efficient way. So these are different sources for real-world data. Now, we do analytics. So we have tools and statisticians in the hospitals, in the organizations can help in analyzing this real-world data through the tools that we have. And we develop real-world evidence. Now, real-world evidence is something which gives us insights with all the data that we have. A data without insight is of no use to us. So if we analyze this and come up with an actionable insight, and then say that this is the unmet need based on the real-world data, and what is the evidence that we have for this unmet need, and what are the interventions that we need to implement to ensure that we cover these unmet needs for the larger population good and patient good. So if you look at applications, there are three major applications of real-world analytics or real-world data. The first one is health economic outcome research. Now, this is very key, particularly when you're introducing a new drug. You need to know to what extent this new drug is beneficial to patients as compared to existing drugs that are already being used. One parameter is you look at effective efficacy and safety of the drug. There is also an additional parameter that you need to look is on the economics. By giving this drug, what is that economic benefit that you're providing to patients or country at large, wherever governments or payers are paying for these patients? So this is an important piece. We'll go more in detail about this health economic outcome research and implications of this health economic outcome research. The second popular use of real-world analytics is population health. Now, when we have to plan public health, we need to understand the unmet need. So first, we need to understand patient's flow in the meaning, what are the presentation, what are the risk factors in a patient, how the patient presents with a specific disease, how this disease is currently being managed in the healthcare facility, how the patients are being given the interventions or medication, and how the patient is behaving to these interventions. This is very vital for us to plan an intervention for population health. So again, we'll go more in detail about population health in the future slides. And the last piece is real-world evidence on treatment to understand efficacy or effectiveness and safety of a drug, so that it helps us to plan our treatment strategies, update our guidelines, depending on the latest data that comes out from these drugs that are used in patient care. Okay, so maybe with this, we'll go topic by topic. We'll cover health economic outcome research, then we'll touch upon population health, and then we will move on to real-world data to support efficacy and safety outcome assessment for various purposes, whether it is decision-making, whether it is regulatory-related work, and others. Now, if we focus on health economic outcome research, first we need to understand what is health. Now, its health is not just a mere physical well-being. As per WHO, health is a composition of physical, mental, and social well-being, and not just merely absence of disease or infirmity. Now, when you're looking at outcomes, when you give an intervention, you look at outcomes in different parameters. Outcomes can be in terms of clinical outcomes. So where you look at effectiveness of a drug, you look at safety parameters, you look at to what extent it will bring down the morbidity and mortality in the population who received these drugs, and helped in improving the function. So these are the clinical outcomes that we assess when we give an intervention to these patients. We also look at humanistic outcomes. These are gaining importance because we have to correlate on the benefit of this intervention into health-related quality of life. Unless we improve quality of life for these patients, we may not be giving holistic care or a holistic solution for the patient need. So we look at health-related quality of life outcomes. We also look at patient preference. Now, while managing any disease, patients should be in the center of the disease care, and patient preference should be given pivotal importance. Now, even when we are working on drug, when we are developing drug, we look at different formulations and see which is that formulation a patient would prefer. Instead of developing a big capsule or a tablet, is it that patient would prefer a granule, or patient would prefer a mouth dissolving tablet, a dispersible tablet, or a dispersible film? So we do conduct patient preference studies just to understand the patient preference so that patient is comfortable and would be able to take the drug, which will enhance the compliance to the medication. Thirdly, caregiver burden is important. Now, as we are progressing in the new era, of course, most of the individuals would be busy with their own work, and caregiver burden reduction is important, and ensure that the quality of life of the caregiver is also taken into consideration. The third piece that we always look at outcomes is economic outcomes. Now we have given the drug, a patient has got benefit, quality of life is good, he or she is taking the drug well, so acceptability is good. Then what is its implication on economics? How it is helping us in bringing down the overall cost burden on a country, or increasing the productivity of a country or a population. So here we look at resource use. Now with this intervention, can I reduce the resource use? Means, can I reduce the hospital stay? Can I reduce the expensive equipment use? Can I reduce the progression to more severe disease so that I will reduce the resource usage? I will increase the productivity of these patients because now patients are well, they can do their job better. I will reduce the burden of illness and then overall provide cost effectiveness. So when we look at assessing the patient outcomes, it's not just looking at whether patient has come out of the disease or not. We need to look at whether the patient has come out of the disease, is he mentally and socially well, and is he economically well as well. Now, when we look at outcomes, there are certain outcome measures that we commonly look into, the data sources. We look at patient-reported outcomes. Now, there are various ways you can look at patient-reported outcomes. This can be through the survey, patient survey that we do, the registry programs that we implement. Some of those devices, like wearable devices, some of those mobile applications which can provide real-time feedback of these patients, help in remote monitoring of these patients. So these will help in understanding the patient-reported outcomes in terms of symptom relief, function improvement, health-related quality of life improvement, utilization of the resources, therapeutic satisfaction and productivity. We also look at observer outcomes. It's not just the patient, but the caregiver or the spouse or teacher in case of children. Now, in terms of frequency of reduction in symptoms, self-care, activity level, we can consider. So clinician reported outcomes in form of whether a study, a well-designed study, or in terms of this real world data that we assess or analyze. And we also look at the performance-based outcomes, like an improvement in the parameters like FEU1 or any other clinical assessments that we do in the routine clinical practice. Now, by looking at the patient outcomes and assessing the patient outcomes, we look at the economics of the treatment. Consider that we are launching or we are introducing a new drug, or a country or a hospital has to decide what drug I need to include in my formulary, right? So when you are deciding, there are several options out there, but you really don't know which option scores over the other. So that's where we look at health outcomes. What are the health outcomes that we see with drug A versus drug B? It can be drug C and drug D as well. So first you look at the health outcomes and see how these drugs will improve the outcomes in terms of patients' well-being, economic, so that the same we discussed earlier. Once you look at the health outcomes, then you look at the cost. What is the cost that you're paying for option A and cost for option B? Now here, we also consider something called direct and indirect cost. I'll not go much into HUR because that's out of the scope of this topic, but just to bring in the context, we do an assessment called direct and indirect cost. Maybe through this lecture, I'll also give you some real life examples so that you can correlate what we discussed today into the implementation of this in the real life cases. So we were launching a new drug, which is a combination of azilastine and fluticasone for allergic rhinitis. Now, we wanted to assess and say to what extent it will be a cost-saving option. So we want to do an economic evaluation. So when you do economic evaluation, when you look at cost A, we look at the cost of the drug. So what is the money you pay to buy the drug is the direct cost. Now, the indirect cost is if you don't give the drug, for example, giving drug versus not giving drug. If you don't give the drug, patients with allergic rhinitis have high chance of progressing or precipitating asthma because normally they coexist because of the allergic condition, background allergic condition. And because of exacerbation of asthma, what additional care is needed, how much of money is lost for managing asthma, how much of money is lost because of reduction in productivity, So you look at indirect cost as well. So you combine direct and indirect cost for intervention versus no intervention, or intervention A versus intervention B, and then you look at the cost holistically. And then you compare cost versus the outcomes. Any two medications, if they are similar outcomes, but differential cost, say drug A, the cost, both direct and indirect, comes lower than drug B or intervention, so then there is no brainer that drug A should be the one that should go into the formulary, whether it is hospital formulary or it is like national drug list, and helps in decision making for the public health officers to introduce policies that can help in driving population health or public health. Okay. So now, where do we get this data? Now, most of this data that we said, direct cost, indirect cost, precipitation of asthma, how we can reduce precipitation of asthma, outcomes assessment with these interventions, most of these come through real world, because the data that we have through controlled clinical studies may not be sufficient to derive all the parameters or variables that we need for pharmacoeconomic assessment. Next comes the population health. Now, what is population health? So so by definition, it is leveraging the evidence that we have in improving the population health, in introducing some intervention and improving the population health. Now, let me give you one example on the patient journey that you can assess before deciding on any intervention. So this is a patient journey, say 6 years ago for hepatitis C in India. Now it has drastically changed because of the introduction of oral anti-HCV drug that has caused paradigm change in the patient care. Now, overall, if you look at the total prevalence of 12 million, the diagnosis is just 1 million. And not all diagnosed patients are going on treatment. If you say 1 million patients are diagnosed, but if you look at number of patients who were getting treated 6 years ago, were 11,000. So there's a big difference between diagnosis and treatment. So there are numerous factors that play a role. And here, understanding these numerous factors are important. And this is what the real world data gives us. It's not just about the outcomes of a drug or an intervention. A real world data will help us understand why there is so low treatment for any disease for that matter. It can be lack of awareness when we looked at, because many of the patients felt that it is an asymptomatic disease, it's non-serious, they have their own myths, taboo, and they did not know to what extent this can hamper the liver issues and the patient well-being at large. It can be non-economic reasons, like there is no infrastructure available. There are alternative medicines available, but may not be proven effectively, or there is no data available to specific drugs that are being used. So you don't know whether the drugs helps or not. There are no policies, government policies to facilitate the patient care. Or sometimes it can be length of therapy or cost of therapy. Now, if you know this through real world evidence, you can intervene. Say if lack of awareness is an issue, you can create awareness. If lack of infrastructure is an issue, you can use the digital technology that's available now and build the infrastructure in the rural areas. Implement policies that can help in patient care. And if cost of therapy or length of therapy is an issue, come up with innovative solutions that can bring down the length of treatment and the cost of treatment. Now, we fast forward now to the present scenario. Since last 6-7 years, what happened to hepatitis C? Now the treatment rates have gone up multifold, so because of reduction in length of the therapy, reduction in cost, there's a lot of focus from the government in terms of education. A lot of things have changed because of the focus on hepatitis C, and that's why we see a completely different patient flow right now if we have to look at for hepatitis C. And this is what the real world data can do for the public health or population health in devising policies and strategies for patient care. So when we want to plan a population health or a public health, it's not just about diagnosing a disease and giving a drug for the disease, but looking at health determinants, looking at the prevalence of the disease, how this disease is being treated, what are the parameters that are influencing this treatment. It can be knowledge, attitude of the patients, knowledge, attitude, and practice of the physicians, patient preferences. Now, looking at all of these, you can come up with intervention for better health outcomes. So wherein you are introducing a measure that is calculated, you know the unmet need through the evidence, and you are introducing interventions. And there is high chance that you succeed with your intervention because it's addressing the unmet need. So this is about population health. So we covered health economic outcome research, very brief overview on how real world evidence really play a pivotal role there. And then we covered on population health, how real world evidence can really help in understanding the unmet needs and coming up with policies to meet those unmet needs. And last, let's look at real world evidence for therapy outcomes, efficacy and safety of a drug, evaluating the outcomes of an intervention. So for any real world evidence, whether it is a prospective real world study or a retrospective real world study, you always look at the index event. Index event is the time point when you diagnose and treat a patient, is the index event. Now we can go before to look at pre-index, which gives us an idea about the demographics of the patients, what are the comorbidities patients have, and the risk factors associated with the disease. With this, we can understand what are the parameters that are influencing patient outcomes. Based on that, you can customize treatment for patients. Now, if you go forward, post-index, you will know the patient behavior, the adherence of the patients, how many times patients has visited, inpatients, outpatient visits, what is the morbidity, how the patient outcomes were, what was the mortality in this patient. So you would know the outcomes of specific intervention that you are starting at the index event. So it always has an index event, pre-index where you look at demographics, comorbidities, and risk factors, and the post-index where you look at outcomes. Now, again, this can be retrospective and post-prospective. Let's look at some of the variables that we normally look at real-world evidence. Of course, this depends on the objective of a study. But if you want to generalize, what do we look at variables in real-world evidence? If you look at pre-index, we look at patient demographics and socioeconomics. It can be patient's age, sex, region, a payer, whenever it's payer funded, the patient's body weight, risk factors, lifestyle, socioeconomic status. So these can provide a key information about the patient's condition, and we can correlate this to the outcomes of the patient. Then we look at more of post-index, whether it is participant-reported clinical outcomes, whether it is self-reported outcomes, knowledge and health beliefs, looking at quality of life, satisfaction. This all we discussed in the previous slide, productivity, compliance to treatment, and the medication usage. But we also look at resource utilization. In a resource-constrained setting like us, we need to judiciously use the healthcare resources that we have. So resource utilization is also a key consideration whenever we look at effectiveness of any intervention. So to what extent we are reducing the healthcare resource utilization by one patient so that the existing healthcare resource can cater to many more patients for their needs. We also look at out-of-the-pocket expenses to know how the treatment is benefiting versus the cost that is being incurred because of this treatment. Now I'll show you, like, if you go back in the retrospective data analysis, so how does a patient flow chart look like? And then I'll give you some example on a real life example on how do you assess a retrospective data analysis through the healthcare data that's available out there, a structured healthcare data that's available out there. Now, if you look at patient flow for a retrospective study, you can start with risk factors. So I would say, look, I want to see intervention of a specific drug or a device in a larger population. First, I'll say, I look at all the population who have risk factors for a specific disease. Then I go back and look at only those specific individuals who had disease with risk factor. So I know the risk factor population. I come down to the disease population with comorbid condition. And in this population, I would specifically look at those patients who are treated, who are prescribed with medication. It's not that all patients who are prescribed with medication will take the drug. So we will look at initial prescription fill, means the purchase of the drug or the patient buying the drug from the pharmacy. The prescription fill doesn't give us an indication that patient is taking the drug. So how do we ensure that patient is taking the drug? By assessing the subsequent refill, we would know what's the compliance of these patients. And then just the second refill alone is not sufficient. Then we need to look at subsequent refill. So here we will know the compliance to medication, and we also look at outcomes of any intervention on the patient. So this is the normal flow that we adopt whenever we do a retrospective data analysis. Now let me give an example, a real life example. We wanted to understand what is the prevalence of pancreatic exocrine insufficiency in patients who have undergone gastrectomy, and how many of these patients are on exocrine replacement therapy. Now, if patient have their stomach and duodenum removed, it will not means they will have deficiency of hormones like secretin and CCK that will stimulate pancreas to release pancreatic enzymes. So pancreatic enzymes are not released efficiently. Because of that, patient will have exocrine insufficiency. And we all know pancreatic enzymes help in digestion of fat mainly. It also helps in digestion of proteins and carbohydrates. So the digestion of these key nutrients suffer, which we call it as PEI, that is pancreatic exocrine insufficiency. And the treatment for this PEI is PERT. PERT is pancreatic exocrine replacement therapy. Means we give enzymes from outside through an entry-coated tablet or a capsule for patients to get the benefit of the pancreatic enzymes. Now, we didn't know about this because not many surgeons know about PEI. They may not actively look into PEI, and they may not even treat PEI with PERT. So if they don't treat, then patient will have morbidity and the survival gets compromised for these patients. So we wanted to understand what is the estimated number of gastrectomy patients in EU5 countries, means 5 major countries in Europe. And specifically in these gastrectomy patients, we wanted to see what are the screening rates for PEI. Do the physicians know about PEI, surgeons who have done the gastrectomy, or the physicians who are treating these patients post-gastrectomy? If yes, then how many are being diagnosed with PEI? How many of them are being treated with PERT as per the guideline recommendation? Are they using appropriate dosages of the PERT? Because most often it is given as a low dose or like underdosed. What's the compliance to treatment? And what are the outcomes that we are seeing with PERT? And what are the characteristics of these users? Whether it is patient, to know knowledge and attitude of these patients is important whenever we are devising any intervention. What are the characteristics of the physicians? Again, knowing about physicians is helpful to help in training or educating those physicians on evidence-based practice. For that, what we did, if you look at the developed world healthcare database, they document each of the parameters in terms of international classification of disease codes, ICD codes. Nowadays in India, majority of the major hospitals are doing this. And that's a great change that we have seen over the last few years in India. There are many organizations who are emphasizing this because they do value real world evidence in patient care. And the insights the real world evidence brings in ensuring that we adapt our resources and treatment strategy for patient well-being. So what did we do? We looked at the data source. There are many data sources that are available. Say IQVIA is one of the rich data sources. They provide patient level data. We have a data source called SIGDAM. There are many such data sources. So what we do is we go and provide the ICD code and say, look, these are ICD codes which indicate gastrectomy. Can we know how many patients have undergone gastrectomy in last 10 years in EU5 countries? So we get the number. So once we get the number, then we want to know whether these patients were screened for PEI. So what we will do, we will look at some of the symptoms and tests that are done for PEI to see if there was some assessment done on this. So we say, let's look at pancreatic steatorrhea, that is excretion of fat. Let's look at weight loss. Let's look at post-gastric surgery syndrome as a keyword. Let's look at post-surgical malabsorption as a keyword, and malnutrition following GI surgery is a keyword. Now, these are the keywords that we use, and there are ICD codes for these three keywords. Now, we put in these ICD codes in the data platform. We get the data, and we put out on our analytical workbench. So most of us, we use a cloud-based analytical workbench. And of course, the statisticians of the organizations would be very well aware of this. And we put in the ICD codes to extract that specific data. So if we put in the ICD code, I would get specifically those patient records who have these keywords mentioned in the case records. And then we look at those records where there is a definitive diagnosis of PEI by putting the ICD code. And we look at those case records where there was PERT initiated in these patients, again through ATC code, that is anatomical therapeutic chemical classification code, which is again used in these databases. Now here I would know with this that how many patients have undergone gastrectomy. Of these, how many patients had documentation on the symptoms or signs of PEI. How many of these patients were actually diagnosed with PEI as a diagnosis, and how many of these patients were initiated on PERT treatment. And I can also see whether the dosing that's being given is appropriate or not. And I can also see the type of physicians who have prescribed. Of course, these are anonymized data that you normally see because of the patient and physician confidentiality or privacy. But you will know what is the qualification of the physician, the background of the physician, what is the background of the patient, what's the background of the patients who are taking PERT versus not taking PERT. You know? So you can understand the unmet needs and bring in the interventions that will enhance the healthcare, that will promote or facilitate evidence-based management of the disease for better patient outcomes. So that's about the real-world database, the database that's already out there. We are making best use of the database that's out there. We are analyzing the data by putting in the ICD codes and ATC codes, and we are coming up with meaningful outcome assessments. Well, we can also do prospecting. One is looking back The other one is going forward. Even looking back, you can look at health records, you can look at digital health records, all of that which is available at the hospital level. That's very much possible. But let's look at prospective study on a registry, how a registry work. As you might have heard this registry word terminology very often, so I'll not go much in detail here. I'll just give an example of one of the registries that's being implemented by Stanford, and then how Stanford is conducting this registry for patients who are suffering from Refsum disease. It's a rare disease. Normally, registries are done for rare conditions. These are real-world data capture. These will not have any definitive time points for assessment. These are normally done on a really long-term period of follow-up to look at outcomes of the intervention. Now here, in this, the Stanford is looking at some of the parameters of the patients who are diagnosed with Refsum disease. So one is the entry criteria is diagnosis of Refsum. Whosoever is diagnosed will be part of the registry. Now, all of their data will go into this cloud, registry database cloud, and gets documented there. So then they would document what are the symptoms these patients are presented with to see whether the symptoms that are being reported are concurrent with the available literature, or is it something else that they're reporting. We know in COVID, symptoms change so fast from wave 1 to wave 2 to wave 3. So looking cautiously on symptoms are important because we may miss out diagnosis if patients present in a different symptom. Then you look at ongoing management of the disease. You look at the parameters which can determine the disease outcomes like fatanic acid levels, look at dietary information, quality of life. Now, with all these data captured, you can do interim analysis time and again to know what's happening to your intervention. So you get real-time feedback on your treatment strategy. You can roll this across in different markets. Say, for example, Refsum registry has been rolled in a major countries across Southeast Asia, Africa, Latin America, and US. So you have the data that's getting captured across the world. You know how the patient care is being managed. You know how the outcomes are. So this will help in devising guidelines for Refsum disease. This will help in driving patient support programs for Refsum disease to understand what are the interventions that we need to implement. This will also help in devising a clinical trial program. Now, if you want to start a study, there are some limitations which we can really overcome with these real-world evidence that I will go further in detail in the next few slides. Another prospective study that's normally, I said, in between real-world and the intervention, normally classified as a real-world study are pragmatic clinical studies. Now, these pragmatic clinical studies are the one which will look at intervention without hampering the standard of care. So for example, if a patient is being treated with a specific drug or an intervention for a specific duration of time, and you want to introduce an app, digital application to facilitate compliance, to facilitate patient's interaction with the physician, to facilitate patient following up into the hospital. So then you can have one group that will have usual of care. The other group will continue with the usual of care. You may add a digital app to see what is that additional benefit this digital app will cause into the patient outcomes in terms of compliance, in terms of the measurable outcomes on efficacy and safety. So here, you're not altering how you're treating the patient, but you're adding a tool that can facilitate. So these are not exactly interventional studies. So these are categorized as pragmatic studies, and these studies are being conducted to understand the outcomes. I was talking about in registry, I was telling that these registries help in optimizing randomized controlled trials. Maybe next 10 minutes I'll finish my session. So here, when we do a randomized controlled trial, we will have some limitations. One is subject eligibility. Inclusion and exclusion criteria are important. If we don't judiciously understand inclusion exclusion criteria or devise inclusion exclusion criteria, then there will be too much of a noise than signal. We call signal as the outcome, noise as the confounders. So there will be too many confounders and you miss out on efficacy on endpoints. You may miss out on the real outcomes of any intervention. So understanding inclusion exclusion criteria is key before you start a randomized controlled trial. Site selections are important. If you don't select sites judiciously, we may miss out on the recruitment. Identifying recruitment barriers are important, and understanding the treatment adherence is also important. Barriers to treatment adherence, so that you can put in sufficient checks and balances to ensure that recruitment is appropriate and adherence to treatment is appropriate. Now, real world evidence can really help us to know that. Say whether it is registry, whether it is database, will help us know what type of patients are, how they are progressing, how they are responding, how they are behaving, what are the different centers across the world who are treating these patients and helping them in their disease. So these are the centers that can help in running the study. It will also help in identifying barriers in terms of treatment and recruitment. So this will really help in fine-tuning the randomized controlled trial design and implementation plan. Another key role of real-world evidence is like the silicon control, we call, like historical control for accelerated drug development. Now, you can run a single-arm study and you can have historical control as comparison. Again, I'll give you a real-world life example that we did. We worked with another organization to develop a product called Pritaminid, now being approved for managing extensively drug-resistant tuberculosis. So these are TB patients who have not responded to all the first-line, second-line drug, so they need they are extensively drug-resistant. And the regimen that was available 5 years ago when we started the study, 5-6 years ago, was a lengthy regimen of 24 months of treatment with injections every week, with multiple pills, and the pill burden was so high that patient compliance was an issue. And these patients have to be treated for between 18 to 24 months. Now, when we analyzed the combination of bedaquiline, Pritaminid, and linezolid in vitro and animal studies, in vivo animal studies, we concluded that a short duration of 6 to 9 months should be sufficient, and we don't have to go for 24 months. And based on that, we wanted to design a study. Now, say if you do a randomized controlled trial in this setting, one, patient population is small. The extensively drug-resistant TB population is small. And second, if you randomize, one arm will receive 24 months of treatment, while the another arm, the drug-treated arm, will receive only 6 months of treatment. So there is so much of variability in the duration of treatment, and there is so much of toxicity with the 24-month injectable treatment of phototoxicity, nephrotoxicity, and it's unethical for a patient to be put on a lengthy regimen when we very well know that 6-month regimen of bedaquiline, Pritaminid, linezolid should work well. So what we did was we devised a single-arm study. We went to US FDA and we presented this, the rationale of a single-arm study, and we proposed for a historical control. And of course, the primary endpoint was culture negative status at month 6. And then when we completed the study, in the dossier, when we submitted to FDA, we submitted the historical control group data as well. Now, if you see here, you can match, and these are matched control groups. So to ensure that we avoid the confounders. The control groups were similar in geographic area, age, sex, body weight, and HIV status, which can be determinants of outcome, which can be confounders in the outcome of this trial. So we have to match the confounders. So once we match the confounders, you look at the outcomes, there's no brainer that the new intervention is causing significant benefit in terms of efficacy outcomes, safety outcomes, as well as the duration of treatment and use of usage. So with this, we could get FDA approval with a single-arm study. Otherwise, if you go and say, like, I want to get a drug approval with a single-arm study, it's not encouraged. But now many regulators are very open for historical control arm, in silico control arms, to come up with some innovative ways of doing clinical studies to enhance the introduction of novel drugs into physicians' treatment at the earliest. So real-world evidence can also help in identifying value-added medicines. Now, what are these value-added medicines? These are drugs that have been used since many, many years, but there are still unmet needs, or these drugs can be used for other conditions. Like, for example, drug repurposing. We saw a number of repurposed drugs for managing COVID, and this is a real-life example of how real-world evidence can help. Now, how did we know that steroids are helping? How did we know that inhalational steroids are helping patients with symptomatic COVID? How did we know that injectable steroids are helping in patients with severe COVID? Because initially it was noted in real world data, and then a study was conducted to reconfirm the real world data. So that's the power real world data has in terms of repurposing the existing drug in expanding the indication of usage of a drug. This can also give insights into drug reformulation. Now, when we looked at real world data of some of our therapies, particularly in aged patients, they were finding it difficult because of dysphagia. Now you need to come up with a solution to these patients. These insights we get to real world. And then we came up with oral dispersible tablets or films to ensure that these patients get benefit so that they don't suffer from the dysphagia and they don't have any issues while swallowing. We can have complex combination. We can come up with novel fixed dose combination. We can come up with pediatric formulations. For example, if you go back, say 10 years ago, there was no lopinavir ritonavir pediatric formulation available. Now, there was a real dire unmet need. So when we looked at the data, we knew that pediatric population is underserved and there is a gap. So that's where the new pediatric formulations of HIV came into existence since last 10 years. And now the pediatric patients are being managed very well. So that's where rethinking, reinventing, and optimizing treatment are helpful. We don't have to every time invent a new drug to manage an unmet need. The existing drugs can be repurposed, reinvented, reused with some incremental innovation for patient care. And these insights can be gathered through real-world evidence. Now, this is the last session, our last topic on the regulatory requirements. So sometimes regulators ask for real-world data as a mandate to be developed when a drug is being launched. Now, this requirement can be for effectiveness reasons, for efficacy assessment, or it can be for safety reasons, to look at the safety parameters. Now, let's look at efficacy assessment. What's the need of such studies as per the regulatory requirement? Now, if the global studies are done in a population that is other than the local population, say, for example, a study has been done in US and Europe, but we want to launch the drug in India while this drug is not tested in India. Now, there are two options. Either you do a phase 3 study and launch a drug in India, or do the assessment and see to what extent local population differs in terms of PK/PD for the drug, and with sufficient justification, you can do a post-approval study so that you don't delay the launch of a novel drug for the patient care. Otherwise, you lose out 3 to 4 years by doing a phase 3 study and launching the drug every country. And this you can't do in every country, right? It's practically not possible for a phase 3 study to be done in every country. So that's what most regulators are doing is they approve with the global data, but they ask for local data to be developed. I'll give an example of some of the studies that we did in Japan recently. Now, in Japan, they have a procedure called re-examination. In India also, we have similar to this, but there it is followed in a more rigor way. So where we applied for a new drug approval, we got the new drug approval, and then we have to do a post-marketing observational study. It's an observational study. Patient would be treated as per the prescribing information, as per the standard of care defined in the label, and then followed up. Now, this re-examination can be done anywhere between 4 to 10 years. Say if there are drugs with narrow therapeutic index, toxicity is higher, so then regulators may ask to come back with real-world data in 4 years, so that whether they decide whether to continue license for a drug or withdraw license of the drug. If the drug has a wide therapeutic index, well established through Western clinical data, so then it may go up to 10 years. But normally it's around 8 years. So within that period, we develop the data, we submit to regulators. Regulators will re-examine the data that's available, match it with the global data and see if there is any discrepancy in the outcomes. And based on this, extension of label will happen. So these are conditional approvals for a specific period, and real world data needs to be submitted during that period to ensure that the intervention is effective in the local population, so that local population get benefit out of the drug. So this can fast track the introduction of the drug and ensure that local population is being tested and ensured that the drug is beneficial or intervention is beneficial in local population. The other part is safety. This is a well-defined terminology called post-authorization safety studies. These are recommended for the drugs wherein we don't know safety profile completely. These are the drugs that have narrow therapeutic index. We have some safety data available through phase 2, phase 3 studies, but further assessment of safety is needed. So here, past studies are done to identify, characterize, and quantify any hazard that we may see with the intervention. It will help in confirming the safety of the medicine, and it will help in understanding the effectiveness of the risk mitigation measures that we may have put. So for example, when you take clozapine for schizophrenia management, the risk management strategy is you monitor the blood. Without monitoring the blood, don't start clozapine. It's a risk management strategy. Now, does it help or not? That you can do it through real world data to see to what extent it is helping in preventing the complication, so that you are testing the blood and you are giving clozapine only to those who have optimum blood cell levels. With this, I'll just one last slide. I will talk on data protection, data laws that are out there, which are very key and important. Now, every country, every region is having restrictive data access for all the good reasons. Of course, patients' confidentiality, physicians' confidentiality, the local population's data confidentiality needs to be maintained, but there are some flexibility available out there. So there are some laws that have been introduced for this. We have a HIPAA law introduced in US in 1996, that is Health Insurance Portability and Accountability Act. And any data, real world data capture when we do, this has to be in accordance with the HIPAA law. In Europe, it is called as GDPR, that is General Data Protection Regulation, where the requirements are the Europe data should stay in Europe. It cannot go out of the Europe, and analysis need to be done in Europe. While India is yet to launch a specific legislation on data protection, privacy law, Indian regulation does amended in Information Technology Act to introduce separate sections called Section 43A and 72. And these sections will give right for compensation for improper disclosure of personal information. So an organization or an individual can be liable if they improperly disclose personal information of any other individuals. There are several amendments that have been done in last 2 decades to ensure that the law is closely matching GDPR requirement, wherein the personal data is protected, yet the data is available for understanding the unmet need and the larger good of the population. So with this, maybe I'll pause. I'm sorry, I might have gone 15 minutes over, or 45 minutes allocated, since this is an interesting topic. I just wanted to cover all essential aspects. I thank you all for the patient listening, and I thanks to my team members, Kelly, Joe, and Jim, who provided some of the slides that I discussed during today's session. If there are any questions, maybe I'll be happy to address.
Thank you, sir. It was an extremely valuable session, sir. The horizons of our knowledge are definitely expanded. We'll now take questions from our online participants. So one of the questions by Dr. Manthan Kumar is, can you name the social media searching tool?
Yeah. So here, when we do, we call it as social listening. And when we do social listening, we don't look at one specific social media to search for. So this can be Twitter, this can be Facebook. Now, all the data that we enter, so these can be analyzed. So though, of course, personal level data is not available, but these can be analyzed. So Twitter gives us platform free, Facebook gives us platform free, but they did capture our data. So those data are captured, and these data are used for analysis. Healthcare doesn't use social media to a large extent, at least now, currently, but there are many other industries who use this social media channel to data analytics, insight mining, for developing their own strategy. In healthcare, it is coming along. So there, you look at all the different social media channels that are out there, and there are some web crawlers available. It's difficult for somebody to go and search in Twitter, search in Facebook, search in LinkedIn. So what exactly the social crawlers, web crawlers does is, if you put in the keywords, these web crawlers can go and extract those conversations from these platforms and bring in some meaningful assessment and help us know what are the conversations on. For example, when we do some patient education program, what we normally do is we do this social listening to understand what are the key aspects that patients are talking, which they don't know, which they're not aware, and we develop education programs specific to that. And that's what every organization or the governments are planning to do, to customize education needs based on the patient conversation or patient requirements.
Thanks a lot, sir. We now move on to our next question by Dr. Rajesh Nayak.
Yeah, hello, sir. This is Dr. Rajesh Nayak from JNMC Medical College, Hubli. I'm also an alumni of JNMC Belgavi. Thank you for the brilliant session, sir. In the initial slides, you spoke about wearable technology and insurance claims as source of data. So my first question is, what are the challenges, especially in terms of ethical issues in collecting these type of data?
Yeah, so in India, the systematic collection of these claims data is not very well managed till recently. Now there are some organizations who have come up who are helping hospitals to develop an integrated solution. So in most of the instances, hospitals may not link their patient data with the pharmacy data, with the refill data and the assessment. So if you link this and the claims data, because hospitals do manage their claims, they support patients with the claims and they submit for reimbursement. So if you link these and come up with a end-to-end holistic assessment, one can do a much better analysis rather than individual assessment of claims alone or patient data alone or pharmacy data alone. Now, when we are looking at claims, we don't normally, you cannot look at outcomes in claims, but what you can look is the patient types and characteristics. Now, for example, I want to know there are how many patients who have been diagnosed and treated with disease A. So what I'll do is I'll go into a claims database. Say in Europe, there is a well-established claims database available because most of the European countries fund their patients. It's funded by government, either through complete payment or co-pay, depending on the country. So there we can go and we can look at drug A and see how many of the disease A patients have been treated in last 1 year. Say 100,000 patients have been treated. Now, similarly, I can go 1 year before and say how many patients have been treated 1 year ago, 2 years ago, 3 years ago. So then I can know the treatment paradigm, whether it is increasing or it is stable. And then I'll also know the type of drug that were given. I can also know the compliance to treatment, because in the claims, these drugs are also reimbursed in most of these countries. So these claims database, when did the patients purchase the drug? If you purchase today, when is the patient purchasing drug after 1 month, 2 months, 3 months? So the compliance to treatment. Of course, you don't know whether patient has responded or not. That's the limitation of claims alone. But whether how many patients have been treated on a drug, on a disease, what type of treatment was given to these patients, and whether compliance was adequate or not, depending on the number of refills.
Thank you, sir. Coming to the next question by Tahira, they ask, how did you conduct NICS TB one-arm study? How did you avoid the confounder in it, and did it not lead to bias?
Yeah. So, and that's why even while presenting, I said, managing or thinking about confounders well in advance is so very critical. Otherwise, the data, again, I would say the noise can be more than signal if you don't balance the confounders, if you don't take confounders into consideration. Now, when we did a study, so we enrolled all the XDR-TB patients and we looked at the outcomes. When we did the matched analysis of the historical data, each patient was matched. And that's a Herculean task. It's not easy. And that's where all the tools that we have, the sophisticated AI tools that we have, will help us. So matching patients by age, by sex, by body weight, the HIV status, and few determinants that can really cause confounding. You have to match each of them so that the two arms are likes to likes and comparable, so that you avoid the confounders on the outcome assessment.
Thank you, sir. The next question is, what tool are you using for real world evidence data analytics, and can you name some platform to learn those?
Yeah. So what we normally do is we use the cloud computing, as I said. There are so many cloud computing tools that are available. There are tools like R. There are SaaS platforms that are available. There are Unix platforms that are available. Normally, we use Unix platform, which is not a free platform. It has to be paid and bought. It's a more robust platform. And what we do is we bring the data, we put the data on the cloud. We don't put the data on the platform. We put the data in cloud. And that's the wonder about cloud computing. That's what it is, transforming data analytics through cloud computing. We put the data in the cloud and we use our Unix platform to do the analysis of this data in cloud. Again, we use ICD codes, we extract the data, we put in the algorithms for analysis based on statistics, and we analyze the data. There are some free tools available, like R is a free tool that's available in net. You can use it. There are a few others, but are not very well standardized. Yeah, so there are good analytics available, both free and for paid. R can be the one if you want to explore, which is a free resource.
Thank you, sir. The next question asks, kindly briefly explain about nested case studies in single arm study and avoiding confounder event.
Yeah, again, so when you're talking about a single arm study, there should be a reasonable justification on why you're doing a single arm study. Right? I can't do single arm study for each and every disease and go and ask for an approval or go and ask for tell it has a robust data. So you need to have a sufficient justification for any rare disease, any condition where there is paradigm change in the disease management, like I said, in XDR-TB management. With sufficient justification, you can have a single arm study. Otherwise, single arm study may not have great value in terms of outcomes because you have nothing to match to show whether the intervention is really helpful or not. Now, when you do a single arm study with a sufficient justification, again, looking at confounders and matching those confounders with the historical data is very critical. Unless we do that, nobody will accept it as a robust data, right? So at least when we go to US and in Europe, normally what they do is when we apply any new drug approval in US, there will be 14 experts who will be on the panel. And this panel is constituted by physicians, pharmacologists, statisticians, epidemiologists, and have diverse background. And once we present the data, there will be, of course, a discussion on the data validity, and they would do an assessment well in advance from their side before they come to the meeting. It's not that they would be listening to us for the first time. And after that, they would vote. And one has to secure more than 7 votes for the drug to be approved. That means a fair assessment of all the confounders are done before considering historical comparators as a valid comparator for any clinical trial. So we should always encourage, when we are developing comparison data versus any intervention, we should always encourage a randomized controlled trial, particularly if you are comparing head to head with any intervention for at least the registration purpose. But historical controls have their significant advantage in specific population, like in rare disease, like in difficult to treat population conditions.
Thank you, sir. So how much more time will you have for questions?
Yeah. So I have maybe another 5-10 minutes. We can definitely take up questions.
Sir, thank you, sir. So the next question by the is there any open site where we can see and use data for our study?
Yeah. So if you look at US, there are open data sources that are available in US for specific diseases, and in Europe as well. It also depends on what is the disease that you want to assess. Now the problem was this data was not efficiently used by some of the experts while analyzing. And we know the controversy that was around COVID, not just in India and elsewhere, depending on the death rates, depending on various other outcomes. So every country is becoming more cautious. Every country wants to protect their data. They are now not putting in data so much into the public domain. So they are restricted, and it cannot cross boundaries. So that's where there are analytical tools that are available, and there are some service providers who work with the organizations, governments to manage this data and help in analyzing data in the region. So if you ask me in India, can we sit in India and analyze somebody else's data? Today it is difficult. It was possible 2-3 years ago, but today it is difficult because the data regulations are becoming very stringent every day.
Thank you, sir. And I ask Chandrasekhar to please put forth his question. Sir has raised his hand in the participants box. Would you like to ask the question, sir? Chandrasekhar.
Sir, good morning. Can I have a clarification? Dr. Ilamati, professor from Pharmacology, Chennai.
Yes.
Yes, ma'am.
Yeah, the excellent. I want to first appreciate. It's really mind-blowing, excellent lecture. I have some of the points I need clarification. Like you told, for allergic rhinitis, acylastine. But is there any evidence that allergic rhinitic patients, if you put on acylastine, they will not progress to bronchial asthma in a later date?
Yeah. So here more of comorbidity condition, madam, rather than sequential. Most of the patients with allergic rhinitis have asthma. And if they have an episode of allergic rhinitis, it precipitates asthma as well. No, it's more of comorbid conditions. One condition can precipitate another condition. And there is a lot of data evidence available that if you manage allergic rhinitis well, you can reduce the precipitation of asthma. The patient already has both the condition because it's allergic. The basic mechanism remains in an allergic prone individual, but one can precipitate other. If you manage one disease well, you can avoid precipitation of the another disease.
And then my second doubt is, you were mentioning about the retrospective, this real world evidence. So here you have mentioned drug and device. Can diet also be one of the, it's not intervention actually, what they are actually taking?
Absolutely, madam. It can be. Absolutely, it can be. And type of diet also determines a lot. Now, we have done some assessments. For example, again, I go back to the pancreatic exocrine insufficiency, where diet plays a major role. So there, if you see, most of the physicians recommend low-calorie, low-fat diet for these patients. If you ask logic, there is no logic. They feel that if you give low-calorie, low-fat diet, patients will feel benefit or patients will feel comfortable symptomatically. While on a long run, patients get malnourished and patient outcomes get affected. The survivability, the quality of life comes down because of malnutrition or nutritional imbalance. And the real world data will bring in this light. And it will really help us to know, so for example, in whole India, if you want to see how the nutritional parameters or how the nutrition parameters are being provided or decided for these patients, we can say, look, so many patients were diagnosed, so many patients had calorie and fat restriction, while so many patients had good calorie fat restriction, fat intake. What is the outcome in them? What is the outcome in the calorie and fat restriction? And what are the adverse outcomes of that? And why there's a need for optimum nutrition in these patients can very well be done. Food is very well a part of the intervention, and we can definitely assess the benefits of optimum nutrition in patients.
Yes, one more doubt. I'm sorry. I'm just.
No, please,
yeah. You mentioned about the historical control for this bidaculin. So, can you just elaborate on that, please?
Yeah. So what we did was we did a study on, like as I said, combination of bidaculin predominantly linezolid in 3 sites in Africa. So where we developed data in 109 patients looking at efficacy and safety outcome. It was a 6-month study, but there was a flexibility to extend it to another 3 months to look at efficacy and safety outcomes, depending on the culture conversion. Culture conversion at week 8. Now, once we have the data in place, what we did is we looked into the same study sites, the population that was treated before the Nix-TB. There was some population who were also parallelly treated with current standard of care for that country, parallelly, but they were treated as a real world case and documented. So we pulled all the data and we had around 220 patients data collected where we can match these confounders. Say I said patient A in the trial group, patient A in the real world group, they should match. They should match in the age, in sex, in body weight, in HIV parameters. So they should be well balanced, like any other controlled clinical studies. If you see the demographics, all the parameters should be well balanced. That's why looking at historical controls and taking right historical control is very much essential to balance the groups to avoid confounders. Once you do that, then you can be rest assured that the outcomes that you're assessing are likes to likes, apple to apple comparison rather than apple to orange comparison.
Maybe so I'll get your number or email, then I'll get more clarification on that. And my last doubt is this, you were mentioning about this regulatory authorities and in Japan. And I mean, what about this HIPAA and GDPR? You told it's a regulatory authority in Europe. HIPAA is from Japan. And I mean, what about the close-up-in also? I mean, just throw a light.
Yeah, so close-up-in was more of an activity, right? So whenever we do an activity, we follow law of the land. Like for example, say when we are doing any real-world data capture, information about the patient. So then we need to follow GDPR rules in Europe. When we have the platform in place, this platform should have checks and balances as per the GDPR. Means there we have to anonymize the patient data. These should be accessible only through a valid user ID and password. There should be end-to-end encryption to ensure that the data flow is appropriate. The data doesn't leak. Nobody should be able to hack in the data and get the data, because healthcare data is one valuable asset which every hacker would want to try to get into and get that information. So ensuring that health data, the validity is maintained, there's no data leak, you need to ensure sufficient checks and balances. So when somebody is in US, they follow HIPAA rules. So if you look at rules and requirements, these are very similar, GDPR and HIPAA. So like that, every country have their own rules for ensuring the privacy of the patient and the population at large is maintained. Now, for example, when we do a PASS assessment, for example, intervention assessment, now every organization which has close-up-in, they have to do something called close-up-in patient monitoring services. Now, these are regulatory requirements in few countries. For example, in UK, in Australia, in some of the Latin American countries, in US and all, it's a regulatory requirement. So where before giving the drug to the patient, you need to check the blood. That is mandatory. Like how we do TDM, therapeutic drug monitoring for any antipsychotic drugs, to just look at the therapeutic levels. Here we do more of blood levels, because this can cause reduction in platelets, reduction in WBC counts, and it can go so low that it can cause problems. So here one has to check so it's said that no drug without blood. Means first you test the blood, you put in the reports of the blood in the system, then only you are able to put in the drug report into the system. Otherwise, the system will not take, and the patient will not be reimbursed. So money will not be paid by the government. So such checks and balances are being put in as a risk management strategy for close-up-in. Now, for example, you have tried all the drugs that are available for schizophrenics. They are resistant schizophrenic. Now, the option that you have is all these third-line drugs like close-up-in. You have to give them, that gives significant benefit to patient, but you can have a reasonable risk management strategy in place to safeguard patient interests.
Thank you, sir. Thank you very much. And we would like to have your email and
sure,
thank you. Thank you for the organizers also.
Thank you.
Thank you, ma'am. We have reached the end of our Q&A session. Thank you, sir, for patiently answering all our queries. We are glad to have you here today. Coming towards the end, I request Dr. Aarti Bhosle, Assistant Professor, Department of Pharmacology, Kahir's Jain Medical College, and Organizing Secretary, IPS Belagavi branch, to propose the vote of thanks.
Thank you, Pulkit. Good morning, everyone. It gives me an immense pleasure to propose the vote of thanks today on this occasion. To begin with, I would like to thank our esteemed dignitaries, Dr. N.S. Mahanshetty, Principal, Kahir's Jain Medical College, Belagavi, Dr. P.A. Patil, Professor and Chair, USMK International Medical Program, Belagavi, for the eternal support in our departmental activities as well as other activities at our institution, Kahir's Jain Medical College, Belagavi.
I express my heartfelt gratitude to our resource person today, Dr. Ravi Shankar AC sir, for sparing his valuable time in spite of his busy schedule. I gladly thank Dr. Pawan Malhotra sir, Director, Principal, Professor of Pharmacology from Jammu, for sharing the unknown facts and contributions of Sir Ramnath Chopra. I sincerely thank the organizing chairman, IPS Local Branch Belgavi, Dr. Naina Hashilkar, Professor and Head Department of Pharmacology, Kahel Jain Medical College, the President, IPS Local Branch Belgavi, Dr. Eli Khatib, Professor and Head of Department of Pharmacology, Kelly's College of Pharmacy, Belgavi, for their relentless support and guidance in organizing this event. I also thank all the faculty members, postgraduate students from our department for their earnest and genuine efforts to put up this event. I also extend my thanks to all the non-teaching staff and to the Department of Medical Education, Kahil's Jain Medical College, Belgavi, for managing all the logistics and providing technical assistance. Last but not the least, I would like to mention that we are overwhelmed with the response from delegates, as over 400 delegates have registered for this event today. So thank you all for your active participation, and we look forward to meet you at our future events too. Thank you one and all.
Dear dignitaries and delegates, to receive your certificates, I humbly request all the delegates to please fill in the feedback form, which will be shared on the WhatsApp groups and by email. We now come to the end of today's webinar. It was a delight to see your enthusiastic participation. Thank you all.
Thank you all. Have a nice day.
Yes, sir.